Okay, good evening, everyone. I'm Heidi Hooker, the Executive Director of OEMS Region 6. Thank you for joining us. Welcome to tonight's measles update. Our goal tonight is simple: provide EMS agencies with the latest situational awareness, discuss what this outbreak means for EMS operations, and share practical steps your crews can take to safely identify, manage, and transport suspected measles patients. A few quick housekeeping items before we begin. This webinar is being recorded and will be shared after the event. Please hold all questions until the end, but feel free to place questions in the chat as they come up, and we'll address them during a Q&A session at the end. Please remain muted unless called upon. Finally, this is intended as a situational awareness briefing and operational discussion. Tonight is about practical information EMS providers can use immediately. The Virginia Office of EMS requested this webinar because of the ongoing measles outbreak in Virginia and the potential impacts on EMS operations. As EMS providers, we are often the first healthcare professionals to encounter these patients. Early recognition, appropriate PPE, and timely notification can prevent exposures to crews, hospitals, and other patients. By the end of tonight, there are 4 things we want everyone to remember: recognize, protect, notify, decontaminate. And now we're going to give an overview of the measles virus. This is not intended to be an educational session, but only a brief overview. We will have slides with education resources at the end that you can use for your agencies or your own personal use. And now I introduce you to ODEMSA's Deputy Director, Mr. Ryan Scarborough.
Hey guys, thanks for joining us tonight, and thanks Heidi. Measles is a highly contagious airborne viral illness. The important point is for EMS to know that the rash is not the disease. The disease is already spreading before the rash appears. If exposed, approximately 90% of non-immune individuals may become infected. And while many patients recover from measles, measles can cause serious complications, particularly in infants, pregnant individuals, and immunocompromised patients. When evaluating patients, think about the classic presentation: high fever, cough, runny nose, and watery red eyes. Colic signs are also an early indicator. The key point is that patients are contagious before the rash develops, so don't wait for the rash before taking precautions. This image demonstrates the typical measles rash. The rash generally starts on the face and hairline before spreading downward across the body. And for EMS purposes, recognize the pattern, but remember that many of the highest risk encounters occur before the rash is actually present. This is a timeline, and it explains why measles is challenging. Symptoms may not develop until 1 or 2 weeks after exposure, and patients become contagious about 4 days before the rash appears and remain contagious for about 4 days afterwards. That's why we rely on symptoms and risk factors rather than waiting for definitive signs to show. This slide contains the actions crews should take immediately if measles is suspected. Place a surgical mask on your patient if it's tolerated. EMS providers should wear a fit-tested N95 respirator or higher level protection. Use eye protection, gloves, and gowns as appropriate. And most importantly, limit the number of personnel exposed. Every unnecessary exposure could create additional operational challenges later on. If you suspect measles, notify the receiving facility as early as possible. Make sure you use the words possible measles. That allows the emergency department to prepare for airborne isolation and determine the best entrance for the patient arrival. Keep your patient masked during transport and transfer of care if they will tolerate it. And after the call, follow your agency's reporting process and notify your DICO as required. If there's one thing everyone remembers tonight, let it be this one. Time kills measles, disinfectants do not. The virus can remain airborne for up to 2 hours after a patient leaves the ambulance. There is no spray, wipe, or chemical that instantly removes airborne viruses from the patient compartment. After transporting a suspected measles patient, the unit should be taken out of service and ventilated along with equipment according to the agency procedure for approximately 2 hours. Once that time period is passed, perform your normal cleaning and disinfection procedures, and the sequence is simple. Time first, cleaning second. This is the operational issue agencies should be planning for now. And now I'm going to give it back over to Heidi for an update on the current situation.
Okay, thank you, Ryan. As of June 2nd, Virginia has reported 91 confirmed measles cases in 2026. I should note that on Tuesday this week, there were only 77 cases. 7 patients have required hospitalization. No deaths have been reported. While those numbers may seem relatively small, the trend is what concerns public health officials and EMS leaders. This graph shows how the trend is pushing upward. The data shows a very clear pattern. 86% are occurring in unvaccinated individuals, while 75% are associated with the current outbreak in Buckingham County. 92% of most cases are locally acquired rather than travel related. For EMS providers and PSAPs, getting the patient's vaccination status becomes an important part of the patient history. The outbreak remains heavily concentrated within the Piedmont Health District, which includes Amelia, Buckingham, Charlotte, Cumberland, Lunenburg, Nottoway, and Prince Edward counties. However, additional cases have been identified in other parts of Virginia. The outbreak may be centered in one area, but EMS agencies across the state should remain alert. Buckingham County remains the center of the current outbreak. The majority of Virginia's reported cases are associated with this area. Because of sustained transmission, public health agencies continue to monitor the situation closely and have issued additional vaccination guidance for that area. VDH continues to publish identified public exposure locations. What stands out here is that healthcare facilities appear on the list. That reinforces the importance of early identification, patient masking, and hospital notification. Exposure locations change frequently, so providers should refer to the VDH website for the most current information. We want to separate facts from observations. The confirmed facts are the outbreak numbers and the vaccination statistics shown in the previous slides. We are aware of reports of impacts within the Amish communities connected to the outbreak area. However, ODEMSA has not been provided community-specific case counts, so we're intentionally not presenting those statistics. The focus should remain on prevention, public health coordination, and serving all communities respectfully and effectively. Large gatherings increase opportunities for transmission of airborne diseases. Events bring together individuals with varying levels of immunity and can facilitate spread into new areas. For EMS agencies, now is the time to review your PPE supplies, brief crews, and ensure plans are in place should activity increase. The biggest impacts for EMS agencies are likely to be operational. Suspected measles transports may result in ambulance downtime. Exposure investigations may infect staffing. PPE utilization may increase. Strong communication between the State Office of EMS, the regional EMS councils, EMS agencies, hospitals, and public health partners will be essential. Now is a good time for EMS personnel to verify their MMR vaccination status or documented immunity. Having that information available can make exposure follow-up much easier if an incident occurs. Just because you have been vaccinated doesn't mean you cannot get it. About 1 to 3 vaccinated out of 100 can still be affected with measles. If you believe you've been exposed to a suspected measles patient, follow your agency's
Join the meeting.
Notify your supervisor and work through your designated infection control officer at your agency. Public health and occupational health partners can then provide guidance on any necessary follow-up. Most importantly, remember that prevention is our best tool. I'd like to now turn things over to Dr. Alan Yee, ODEMSA's Regional Medical Director and also currently the state interim OEMS Medical Director, for his perspective and operational per operational medical directors. Dr. Yee?
Thank you very much, Heidi. From my perspective, this is something that's unusual for the region, right? We don't see a whole lot of measles outbreaks. Historically, over the last couple decades, we've seen sporadic cases here and there. My concern about this particular outbreak is the significant increase in cases over the past week and what we're expecting to see over the next several weeks. As these large gatherings happen that Heidi's talking about, we expect there's the high likelihood of a increase in the number of cases. And obviously, as these large gatherings happen and the infected patients go elsewhere, go back home, we risk the spread growing even further. This also comes at an inopportune time that we also have a rise in other respiratory viruses that will present almost the same way. When we're seeing that Circata COVID arise, where you're getting the same fever, cough, and body aches, same thing like that a measles will present with. So everyone needs to be hyper aware of treating febrile illness and treat it accordingly using appropriate PPE. Our goal in the future, near future, is going to be making sure that we coordinate with the Office of EMS, VDH, and have a cohesive plan across the region, so that way we minimize any impact to our agencies. Otherwise, I'm happy to answer any questions that you have.
Okay, Dr. Yee, thank you. And we will have a question period at the end of this.
All right. So are we unmuted now?
Yes.
Okay. And now we're going to turn it over to Mr. Jeff Tanner and Mr. Jimmy Mitchell with Centra Paramedicine Services, Lynchburg General Hospital. They've been called upon to handle the Buckingham outbreak and will share their perspectives.
Jeff, do you want to go first or do you want me to start?
I'll let you go ahead.
All right. So 2.5 or so weeks ago, we were contacted by the Department of Health asking. They knew about the community paramedic program through Centra. They knew that with Farmville Hospital that we were fairly close to the Buckingham community, and asked what type of resources we had, if we could help put our heads together with them to determine if there was anything we could do. Of course, this community is a little non-traditional in thought about medicine. There are several things they don't like. They really lean on, for lack of a better term, some of the elders or counselors in their communities to help them make decisions. There are several people usually living in a house. So all the challenges that come with a tight community that typically aren't very well vaccinated, if at all, that have a lot of community functions and things going on and are interacting with each other, raised some concerns. So at that time, we had the bandwidth to be able to say, if there are folks that aren't wanting to go to the hospital, but we need to try to treat in place, so to speak, we came up with some treat in place protocols, kind of tiered those into 4 tiers, everything from a well check to Tylenol and Zofran for nausea and or fever and pain control, fluid resuscitation if need be, all the way up to IV, IG infusions, which we have not delivered any at this time. So since they contacted us, we came up with an operational plan. We met several times to try and get something formalized well enough that we were coordinated and fairly consistent in what we did. One consistent contact method for the program, consistent protocols, and Friday afternoon, after the Friday morning meeting, the information was released to the community and we started seeing people that evening. To date, we have had about 20-ish, give or take a few in either direction, patient contacts. We've treated as many as 3 folks in the same household. Several of the people who have had exposure or had the measles have not had symptoms bad enough to reach out. So it's 22 family community in that area or in that church in the Buckingham area. And we saw about, 20-ish of those individuals for treatment. A couple of folks did have to go to the hospital for transport for continued care, pediatric. And that's kind of the 30,000 foot overview. Some of the challenges are distance, depending on where they are in the community, time of day that they call or that they feel that they need to reach out. We've gotten calls during the daytime, during the afternoon, weekends, some at night and in the middle of the night. In some cases, in a 24-hour period, we've made several trips. We have good contacts through the Department of Health who are very much in contact with the midwives and the leaders of that community. They have done a really good job of helping establish some trust with us in the community and allowing us to come in. We have been very well received with the program going in. They are reaching out to us on their own in many cases. It's not just, an EMS referral, or the Department of Health. A lot of times we're notifying the Department of Health of the next person that has shown signs or symptoms. So the program we feel like has been very successful as far as cutting down on EMS responses, on cutting down on ER visits for these people, being able to treat in place, and um, keep them at home, which is also lessening the exposures for these individuals. One of the other things we did was reach out specifically to Buckingham EMS, let them know that we were going to be in their backyard, that it was nothing but us trying to help the Department of Health and help the community. And we gave them the same information about how if they felt there was a need for them to refer back to us, they could do so. So there again, very small scale, one church, probably less than 150, definitely less than 200 people, but probably less than 150-ish people, 22 families. And there again, just as everyone has said, this is informational and awareness and for folks to be able to know that with some of the public events coming up, there's potential that it can move outside of that church and that little community where it started at. Jeff, is there anything you want to add with what we did?
No, you hit everything I would have added. I was going to talk about the potential of spread with the upcoming events in the warmer weather. That's the biggest thing here. For tonight, we want to make sure everybody's aware that it's the potential that it may reach outside of that church and outside of that initial community and spread rapidly once it does with some of these events.
Okay, Mr. Tanner, Mr. Mitchell, do you have anything else to add?
No, ma'am. I think just like I said, the 30,000 foot, overview, there are a lot more specifics to what we worked on and part of the plan, but just giving an idea of what we were doing for that specific portion of the community.
So, hey, this is Dr. Engel with Centra. I'm the Senior Medical Director for Pediatrics. I was just going to add that I really want to give a shout out to the strong work of the community paramedic program in limiting the number of people who would have potentially presented to the emergency department in a very safe way and preventing potential exposures there. But also add that the vast majority of these patients were treated symptomatically in the field with just supportive measures and evaluations. So the vast majority of patients don't necessarily require hospitalization. I think that's been a big testament to the work that they've done. So.
Okay, thank you. We'd now like to welcome Mr. Chad Mason. He's the Virginia Office of EMS Division Director of Emergency Operations for comments regarding the state response. Mr. Mason.
Can you hear me now?
Yes, sir, we can hear you now.
Awesome. So first and foremost, I want to thank everybody for coming on tonight and letting us reach out to you. And to everybody's point earlier, the biggest thing is education. And Central and the Department of Health resources that have been working on this outbreak over the last several weeks, monitor it to see at which point we can start seeing impacts to the local EMS system, and it's possible that we've reached that point. In the background, we are working internally within our office and VDH as a whole to develop action plans to know when we reach the trigger point for local EMS response, that we have a plan ready to go, and steps are in place so that we can address this issue as possible within the Commonwealth and keep our responders safe. And that's the overall goal, right? Is make sure that we're safe while we're out there treating these people that need our help. And that's the main goal for the office. And just wanted to let you know that the office is here to support our providers in the field. So thank you once again, and I will hold off for any questions.
Heidi, we can't hear you if Ryan is talking.
I'm sorry, we did not unmute, so we will.
You missed the best part of the presentation then.
Yeah, we're done. Sorry, guys.
So, again, thank you, Chad. These are our primary resources that were referenced throughout tonight's presentation. We'll continue to update the ODEMSA site with information as it becomes available. If you haven't already, please check out odemsa.net. We've got lots of resources, including some sheets that you can use for your providers to help them know what the steps are for decontamination. VDH remains the authoritative resource for outbreak data, information, and exposure sites. And then for agency-specific policies, continue to follow your OMD, DICO, and local policies and procedures. And there's additional information that can be found on the Virginia Office of EMS's website as well. So at this time, we're going to go ahead and open up the floor for Q&A. Please raise your hand and wait to be called on. And do we have any questions? You can put them in the chat, or you can raise your hand and we'll unmute you. Oh, actually. All right, we have something in the chat from Jerry Marino. We heard about the need for plans from both ODEMSA and the state. When will we see these plans?
ODEMSA has resources on our homepage of our website that we referenced in the previous slide.
Yes, ma'am.
And
I think
also
Dr.
the-
G talked about the need for a comprehensive plan for the region, a regional response plan. And the state talked about also having a response plan to keep providers safe. And I'm just wondering, are these going to be documented plans that are going to be made available to us to review? And if so, when might that be?
So we are working on that right now. The hope is in sometime early next week. There are follow-up meetings following this meeting tomorrow, to where we can start figuring out how that's going to look and pulling the data together, and so we can get something out there that isn't premature, that is thought through and validated through the stakeholders that need to validate it. But the hope is sometime next week that we'll have some kind of deliverable out there to the providers in the field. If not, we will push out those communications probably through ODEMSA to let everybody know when we kind of can expect something. But we are currently working on something in the background to get out to providers.
Thank you very much.
And also to answer your question, in the ODEMSA protocols, we do have something that addresses this already, section 1211. But it does not, of course, parse out, the measles, but we do have something that covers infectious disease incidents. Our guidance on the website is what we're recommending agencies and providers do specific to the measles. And of course, like Chad said, we will be working closely with the Office of EMS, and we will forward any other guidance that we have out.
In the meanwhile, I believe that agencies should, review their infection control plan, which should address the majority of all this, and speak with their occupational physicians and operational medical directors for any modifications to standard operations.
Okay. All right, we have another question from Ryan Martinetti. I'm sorry if I'm not saying your name right. What is the timeline between testing, confirmed positive, and feedback to EMS providers that came in contact with the patient?
Dr. Yee, can you answer that for us?
I am unfamiliar with the specifics of the timing of the notifications in this particular case, but upon identification of measles, the hospitals are required to notify the agencies immediately. The issue is, the biggest issue is not about notification. It's not the notification. It's the identification without the rash. That's our biggest concern right now, because they still are infectious early on with the fever and cough, and don't have the classic rash in the skin or the mouth.
I just want to take a moment to remind providers that if you are exposed, there are exposure reports that ODEMSA provides to the hospitals. They're in every ER. So you want to make sure that you fill that out.
Hey, Hattie, real quick. I've had several people ask me that if they had the measles when they were a kid, does that mean that they're immune for life, or do they need to follow up? Or
I can take that, Heidi. In theory, if you had measles as a child, you should be immune. However, if the measles have changed some of their genetic makeup, like it mutated a little bit, there is still a chance of a measles infection. But usually when that happens, the symptoms are minimal. Same thing goes with the vaccine. The vaccine is not 100%. Even if you're vaccinated, there's still a small, but a chance, but it is there of contracting measles.
Thank you, Dr. Yu.
No, man, go look at my.
Okay, thank you for your question, and thank you, Dr. Yee. We have a hand up, Dr. Travis Engel.
Yeah, thanks. I was going to say our experience regarding the earlier question about what's the turnaround time from testing to notification, et cetera. Our experience with VDH has been, if it kind of depends on the time of day. If it comes during business hours and VDH can be made aware of the possible measles, like our suspicion for measles, they can collect the testing and usually get it to Richmond where they run the PCRs that day, and you can usually get some form of notification in 24 to 48 hours. The testing itself doesn't take a particularly long time. It's the couriering of the test over there. If it comes after hours or over the weekend, the timeline it gets a little longer. At Centra, we've got kind of a two-pronged process where we'll draw our own samples and also VDH samples if we're not able to get a hold of VDH that evening. So that might be something for other facilities to consider, because we don't know if VDH will accept the suspicious measles case when we report it to them. So sometimes we have to collect the samples before we know VDH will consider it suspicious for measles. So, and do their own and choose to do the PCR testing and the serology testing in Richmond. So there's a couple things to think about that. And the other thing I'll say is just presumptive immunity. If you've had your full MMR series, if you've had measles previously, you're born not before 1957, you've got presumptive immunity. Although, as Dr. Yee said, you still may be susceptible, but currently CDC does not recommend routine titer testing, which is why the PPE is so important. So I just want to put that out there. Again, I've just been kind of at the nidus of some of this stuff. I'm very keen to share any information that we've gleaned along the way, because we've been kind of swimming in it.
Okay, thank you. We have a couple questions in the chat. Go ahead, Ryan.
All right. Chad, this may be up your alley. This is from Devin Sneed. Is there going to be any special reporting structure put in place for tracking purposes outside of normal operations?
So that's going to be one of the things we're going to be hammering out while we have these discussions about this pre-planning and what should the plan incorporate. So that will be part of the discussion that we'll be having. And just so that everybody does know, everything we're talking about tonight that is going to be germane to that, what our future planning will look like going forward. I am taking notes, so be rest assured that your questions are being noted for follow-up.
All right, we have another question in the chat from Gail Weatherford. If someone is immune from vaccine or prior infection, can they still spread measles after exposure, even if they don't develop measles themselves?
Ryan, this is Yi. I don't see how they would be able to spread if they are not infectious. I just don't see it. I don't see how they would do it. But I always hesitate to say never. I would probably say it's highly, highly unlikely. Now, you could spread infectious fluid if there's but through airborne, there should not be airborne spread.
I think to Dr. Yee's point, that agrees with the CDC recommendation that if you are presumptively immune and you are wearing proper PPE, even if you had an exposure without PPE, the CDC does not recommend any specific prophylaxis or quarantine period for individuals who are presumptively immune and not showing signs of active infection.
And to go back, I believe it was Gail's question about reporting. I believe that measles is a required reporting to the to the health department / CDC. So once a confirmed case is identified, there is a regulatory requirement to report, and that's usually from the health department, doctor's office, VDH point of view. On the EMS agency level, it is we would not know any confirmed cases, so I'm not sure we would legally have a requirement to report.
Dr. Yee, to your point, when I was reading the VDH website earlier, it looks like we don't have any responsibility to report as EMS, but it does look like the hospitals and healthcare providers at clinicians do have to report. So. No hands up.
Okay, we are not seeing anything else in chat or any hands raised. This is a last opportunity to ask the questions. Looks like we have something coming in chat.
All right. Tracy, I'm not going to slaughter your last name, said, we are usually calling VDH as soon as we suspect, not waiting for results. And then Gail Weatherford, can you comment on the age range for persons that needed to have an updated MMR?
So if I recall, the CDC recommendations, and I have to specifically go back to look at it. They recommend a MMR booster as an adult. So I would, most of us got our MMR as a child. So, you know, if you have a second dose in the 20s, you should have adequate immunity. This is something we can double check on and push out any additional information as needed.
Yeah, you should be fully vaccinated by the time you're 6, essentially, if you follow the CDC vaccine schedule as a child. There's no routine MMR recommendation for a booster as an adult. If you've had 2 doses as a child following the CDC schedule, beginning at 12 months and then I believe 4 to 6 years of age, you've had your 2 doses, you're presumptively immune. If you were born between 1957 and 1968, you may specifically require a booster, but otherwise, prior to 1957, prior infection, full 2-dose MMR series, you're presumptively immune.
I stand corrected to Dr. Engel.
I'll also just put out there, and again, this is just no disrespect at all, Dr. Yee, because it's just my wheelhouse being in peds. I would say too that there's no routine recommendation that healthcare providers necessarily get routine titers to prove immunity, because even with negative titers or suboptimal serology titers, you may have sufficient cellular immunity to still be immune. So titers alone don't necessarily prove immunity, which is why CDC leans so heavily on the idea of presumptive immunity. But to the point you made earlier, there's a very small subset of individuals still susceptible, even with presumptive immunity, regardless of what their titers may demonstrate or their prior vaccination or disease status may represent.
All right, we have another question from Angela. If you only ever had 1 dose, then should you get a second dose? And then if you had your first dose if you had your first dose in the 1960s, South Carolina did see a few measles cases where the vaccination failed. So I guess she's trying to figure out if she should get a titer run or get a booster or get a second shot.
This is Angie West. Sorry, I actually work for the health department. So I'm just trying to answer the question for people. So if they only had one dose, it would be a good idea to go ahead and check and get a second dose on record, especially if you're going to be in the homes with these individuals. But I was just letting people know too that if they have documentation, but if their documentation was from that original measles containing vaccine that was back in the 60s, that we are aware from some of our other states that they have seen more vaccine failure with that original vaccine than they have with the live virus MMR that we use, now and that we've used for multiple decades at this point.
And I think I can safely add here that if you are unsure of your vaccination status, if you're unsure if you, need anything additional, you probably should have a discussion with either your primary care physician, or you can also probably have a conversation with your agency's operational medical director, who could also guide you with this.
This should be outlined clearly in your agency infectious disease plan, because this is a requirement of CDC, which makes it a OSHA requirement.
Mm-hmm.
All right. Another question from Gail Weatherford. Is there a problem getting another dose vaccine if you don't know if you already had a second dose?
No, this is Angie again. It's fine to get an additional dose. There's even people who will get their immunity checked and are found to be not immune who decide to get additional doses of vaccine.
Do we need to stop and get yours?
We did have someone share in the chat a link to find vaccination records.
Just to note that those vaccination records may be incomplete, especially if you're older and your pediatrician vaccinated you. They may not be entered.
We are
sorry,
not.
Angie, I'll second that just so people are aware. Like, I'm in my 40s. I grew up in Virginia. Like, my vaccines were not in the VIS system. But I do have like my vaccine records from when I was a child. So, I mean, I think probably a lot of you are in that same boat where you're not actually going to be able to find your vaccine records in our immunization system because it didn't exist when we were little. But sometimes you're able to find them. Like, I was able to find mine actually in my college application packet.
Hands.
Okay, we're not seeing any other hands raised at the moment. We don't see anything in chat. Last chance to, we do have something else coming up.
Jen Cameraman is asking, are there any concerns in the long-term care or assisted living communities?
Hey, this is Angie. So I don't have any right now. Like, we're not aware of any of the people who have measles that are working within those communities. Certainly, we have concerns within those just in general that you can end up having patients who may no longer be immune. Because of having had like autoimmune conditions or being on auto or immune suppressive drugs. And then, of course, with younger people who may not have been vaccinated, that's part of why we put out the outbreak notice as well, just so that everyone could kind of know what was going on. I mean, just in general, to like keep in mind with the outbreak, this is very much like limited right now to this one population, but there is the potential for it to spill over into any area within the community, into the more like general community.
Thank you, Angela. Okay, we do not see hands raised or anything else in the chat. I just want to take a second and say, you know, we were asked to do this just day before yesterday, I think. So we want to thank you for joining us on such short notice. You know, when we're requested to do something like this, we try our best, you know, to put something together that works for everybody. I want to thank the experts that joined us that helped answer questions. We really appreciate that. We knew that there would be some on, and we kind of relied on that, so we thank you. You know, we will be sharing the recording from today's meeting. If you remember only 4 things from tonight, think measles, protect early, notify early, and remember that time kills measles. And thank you for everything you do to protect your patients, your communities, and each other. And thank you so much for joining us this evening. We really appreciate it. We hope you found this helpful. And it's very possible that if this progresses, that we would have to meet again. And we will try to be more prepared and give you more time, if at all possible. But thank you. You all have a good night.